start. Is my voice clear?
Ada?
Is my voice clear?
Yes, yes.
Yes.
All right, thank you. Okay, so I am Adrina. Good morning, everyone, and Assalamualaikum. So today, I'll be presenting on peritoneal fluid analysis. So first of all, wait, I need to change the.
Pleural and peritoneal or peritoneal only?
Peritoneum. Pleural effusion already done.
Okay, peritoneal.
All right. So this is an overview of the anatomy of peritoneum. So peritoneum is essentially a continuous, glistening, slippery, transparent serous membrane. And for your information, there are two layers, which is parietal and visceral, as everyone already knows. So parietal peritoneum, it lies the internal surface of the abdominal pelvic wall, so meaning it's from abdomen to pelvis. And for your information, in males, peritoneum is a closed space. However, in females, peritoneum is an open space, like there is ways, to the external part of the body, which is through the tubal, uterine tube, right? And we also have visceral peritoneum, which it invests the viscera. So for peritoneal cavity, it is the space, it's potential space between the parietal and visceral layer, and then it is only capillary thin. And it contains peritoneal fluid, which consists of water, electrolytes, and substances derived from interstitial fluid. Alright, so now, okay, I cannot move the slide. I think I have to stop first. Okay. So in our discussion today, I'll be focusing on ascites. So ascites, it develops from two pathways, which is either there is increased in accumulation or decreased in clearance of peritoneal fluid. So increased accumulation, I think it's self-explanatory. It is because of increased capillary permeability, or increased venous pressure, or decrease in oncotic pressure. And then we can also have decrease in clearance of lymphatic, which is from increased in lymphatic obstruction. So for information, peritoneal cavity usually contains only 50 to 75 mils of fluid. However, in ascites, it is clinically detectable when there is more than 500 mils of fluid in the peritoneal cavity. Okay, wait, I cannot move the slide. I think
Using PowerPoint or Canva?
PowerPoint.
PowerPoint.
Mm-mm.
Usually we can just
Mm, okay. I'll try again. Okay. So I have listed some of the etiologies for ascites. So we have two types, which is transudative or exudative. So transudative, it derives from two mechanisms, which is high in the hydrostatic pressure or decrease in the oncotic pressure. Um, so for transudative, we have here listed liver cirrhosis, and then for cardiac causes, it can be right heart failure or congestive heart failure or constrictive pericarditis. So as we all know that it's much more like it's um, self-explanatory for the transudative. There is only fluid or only water that gets out of the vasculature. However, the albumin it stays in the vasculature. So other than liver cirrhosis or cardiac causes, we can also have renal failure or hyperalbuminemia. And then for exudative, meaning that the ascites is caused by fluid that gets out from the vasculature altogether with albumin or protein. So this most probably we can understand it by inflammation. So it's like easy to differentiate between transudative and exudative is when there is increase in hydrostatic pressure or decrease in the oncotic pressure, and for exudative it is because of inflammation. So listed here, malignancy, venous obstruction that includes inflammation, and then pancreatitis and infections. And for example, like TB. Sorry. Sorry. I think I have to present like this. This one. Mm, okay, I think I just present like this. All right. So now we're moving on to a gross appearance of ascitic fluid. We have here clear to pale yellow, which is normal. As you can see here, or clear to pale yellow, we can also say that it is straw color. So it's normal like this one. And then we can also have milk colored or colorless. Um, Milk colored or colorless is caused by lymph that is obstructed or lymph that is uh, traumatized, or lymph vessels that is in damaged. So in the case of chylus formation of ascitic fluid, it is caused it can be caused by malignant tumor or parasitic infection, any kind of like something that can cause uh, lymphatic damage. So it is from the lymphatic drainage. So why it is milk colored or why it is chylous is because of the lymphatic fluid is rich in triglyceride, is rich in chylomicrons. So that's why the name milk colored or chylous or from chylomicrons, and it is from the intestine or from the liver. So anything that obstructs the lymph that is causing lymphatic drainage to be obstructed, it can cause ascites that is milky in color. And then other than that, we can also have cloudy or turbid, and this one is caused by peritonitis or perforated bowel or appendicitis or pancreatitis, something that is from infection. So from this one, I understand it as infection. It can cause like pus formation, so That's why it is cloudy or turbid in color. And then for another one, which is bloody tap. Bloody in color, it can be from malignant tumor or it can be from hemorrhagic pancreatitis or perforated ulcer. So in the ward, I asked a doctor, an MO, how do we know if once we tap, if it is from uh, tumor or if it is from already formed, perforated ulcer, or it is from the tap itself. Like once we tap the patient, um, we know that maybe the doctor, maybe we perforate the liver, for an example. If we perforate the liver, or it is actually from already there. I mean, like the blood is already been there. So the doctor explained to me that if the blood color, if it is fresh, meaning that um, during the tap, we might, injure the organs.
Meaning
And then
that
if it is,
traumatic tapping lah. Is it
uh,
traumatic tapping? And usually is we accidentally injured the organ or colon or liver or spleen, the efficient will be blood. It's really fresh blood, bloody. It's very fresh blood, and it is hemoserous. Hemoserous, you can see the serous mixed with blood. It's not really like our blood.
yeah. So if the blood is already there, meaning that the blood is dark, meaning it can be from tumor. Right. Okay. Thank you, doctor. So now let's move on to laboratory investigation, the important part in this slides, in this presentation. So here,
Sorry, Adri.
uh-huh.
Doctor.
Mhm.
Sorry, doctor. I didn't get what you were saying. The hemoseries is due to traumatic tapping or causal?
Hemoseries is from or
Can I
already
hear?
formed, right?
I cannot hear you clearly. Can you
Sorry,
repeat again?
doctor. Is the hemoseries is from traumatic tapping as well?
It could be, but not really. Like, usually, we in hemoseries, usually in patient with malignancy, they will have hemoseries effusion, but we have to monitor either is how hemoseries later on become darker or just like bloody. We one of we have to take the precautions, and then we have to monitor the vital sign. Usually, if we hook an organ, we have to monitor the patient, especially the blood pressure, either any evidence of hypotensive episode, and we have to repeat FBC to look for hemoglobin levels. That
Okay, doctor. Thank you, doctor.
Uh, I think I want to add some points to that. So hemoseries, based on my what I asked the MO, the hemoseries could be dark in color. So meaning that you can differentiate between hemoseries or um, traumatic tap. I think that I hope that answers your question.
Yes,
Okay.
Adri. Thank you so much.
Okay. Sorry, I have to I thought it can move already. Okay. All right. So this is the laboratory investigation. Once we tap, so we can send for cell count with differential, gram staining, fluid culture, LDH. But LDH I couldn't find like um the significance we want to send for LDH. But I think we might want to use this for if you want to know the cause of the ascites is from maybe heart, you know, liver, something that is related to LDH as well. And then we can also send for glucose cytology tumor marker, albumin, and SAAG. But this one later on I'll share. I'll explain it in details. So for cell count, as you can see here, in normal studies, we have less than 500 leukocytes over microliter, and then for polymorphonuclear cells, it should be less than 250. And based on an article I read, if PMN, if polymorphonuclear cells are more than 250, it could be suggestive for spontaneous bacterial peritonitis, SBP, spontaneous bacterial peritonitis. And moving on to SAAG should be SAAG, but this one I'll explain in more detail after this. So SAAG, if it is more than 1.1 gram deciliter, it is transudative, and if SAAG is less than 1.1, it is exudative. So other than that, we can also send for cytology. So for cytology, we can detect for malignant cells in the tab in the cytis fluid. And other than that, we can also, if we suspect for suspected peritonitis, pancreatitis, so we can look for amylase. And then for protein, if the protein in the cytic fluid is less than 2.5 gram deciliter, it is classified as exudative. And if it is greater or equal, it is transudative. Other than that, we can also find for glucose, if it is similar to serum level, it means it is normal. And then if it is less, it could mean that maybe there is malignancy or TB. And then we can also do gram staining or culture. And one of the examples for spontaneous bacterial peritonitis is that there is approximately, it should be more than 10,000 bacteria for the gram stain to be, detected in this. All right, so this is like one of the most important thing in these slides. So we have serum ascites albumin gradient, or what I mentioned before as SAAG. How do we count for SAAG is that the serum albumin we minus by the ascites albumin, so we get SAAG. So essentially, serum albumin is higher than ascites albumin. So in a case of like SAAG is more than 1.1 gram over deciliter, okay, it means that the serum albumin is higher than the ascites albumin. Okay, so in in a case of SAAG is more than 1.1, it means transudate. So how do we understand this? So in the serum, the albumin it doesn't get out in transudative osmosis, it doesn't get out. So the water only gets out, the albumin stays in there. So when albumin stays in there, the albumin outside, or the albumin in the ascitic fluid, it will get diluted. So once it gets diluted, the ascites albumin will be lowered, right? So the albumin in here is higher. So meaning that if we give number like 4 minus by 2, we get positive number. So we get 1.1. We get more than 1.1. So meaning that the SAAG is more than 1.1. So it means that it is transudative. All right. So for exudative, the SAAG will be less than 1.1. In this case, it is not only the water that gets out of the vasculature. It is also the albumin. So the serum albumin will get lowered. However, the ascites albumin outside here, because the albumin also gets out, so the ascites albumin is also increased, meaning that if we give number like for sorry like if we give number to this, the lower one minus by the higher one will get lower number or a negative number, right? So we can easily remember this by the SAEG will be lower than 1.1 gram over deciliter. So transudative is caused by pathology like increase in hydrostatic pressure and also decrease in oncotic pressure. And for exudative, it is most likely inflammatory causes. All right, so now let's move on to Q&A. Just to recall back and just to test your understanding on SAAG. So we have here the first question. If we have left-sided heart failure, we can then have pulmonary edema, right? So from the pulmonary edema, we can have right-sided heart failure as well, right? So from right-sided heart failure, we can develop ascites. So what do you guys think? If it is it transudative or is it exudative for the first one? Is there anyone who want to try? No one want to try. Okay, so for the first one, left-sided heart failure, and then it develops into pulmonary edema, and then it can cause right-sided heart failure, right? So right-sided heart failure, we know that it is transudative. It should be transudative because of the high in the hydrostatic pressure. So high in the hydrostatic pressure, meaning that the SAAG for the first one is more than 1.1 because it is transudative. Let's moving on to the next question, which is kwashiorkor, or not eating protein. We have low protein in the vasculature. So this one, we have low in oncotic pressure, right? So low in oncotic pressure, is it exudative or transudative, you guys think? It should be transudative, right? It cannot be exudative. So the SAEG for the second question is more than 1.1. Moving on to the third question, which is severe liver disease or cirrhosis. So we know from cirrhosis, it's self-explanatory, that we have decrease in albumin or hypoalbuminemia. So in this case, low oncotic pressure will cause transudative ascites, and then the SAAG will be more than 1.1. All right, so moving on to the fourth question, which is nephrotic syndrome. So nephrotic syndrome, we know that there's also there's also decrease in the albumin or hypoalbuminemia. So the same. It is the SAAG will be more than 1.1, meaning that it is transudative. And then for the fifth question, for this type of disease, protein losing gastropathy. So protein losing gastropathy is also self-explanatory, same as these two. So meaning that it is transudative, right? Because of the low oncotic pressure. So another one, malabsorption syndrome, cannot absorb protein. So meaning the same thing, transudative as well. All right, so now we move on to another question. Acute chest syndrome or sickle cell disease. What do you guys think? Is this transudative or exudative?
Exudative.
Alright. True. It should be exudative because of it can cause inflammation, right? Sickle cell disease and whatnot. And then pneumonia. What do you guys think?
Exudative.
True.
Exudative
Correct.
also.
Okay. For tuberculosis,
Exudative.
exudative. For lung abscess,
Exudative.
right? And then same as bronchiectasis.
Yeah,
And then
because of
this
the
one.
inflammation.
Yeah, okay, correct. Thank you guys. So I think that's all from me. Thank you for your attention.
Yeah, thank you. Um, so in peritoneal fluid, the most important thing you have to differentiate either it is transudative or exudative, and then from there we can further classify, and then we have to understand the causes or the principal causes behind the transudative and exudative, and then it can lead to our we can find the causes behind either is exudative and exudative or transudative. Apart from transudative and exudative, we also have to know the SAAG, because the important thing for SAAG is about the portal hypertension, because we can know either it is involved with portal hypertension or not, because the management is different. Okay, any other question? I think you all understand quite much, right? Because you already do some practice just now. If no other question, we can move on to our next topic. Usually in OSCE, they can give a simple scenario. Let's say patient presented with abdominal distension for a few days with bilateral leg swelling, and then you have to get the history related to the scenario, and then they can give you the peritoneal fluid analysis, and then you have to calculate a simple one just like SAG or transudative or exudative, and then later on they may ask you how to confirm, how to further investigate this patient. It's only 10 minutes. Okay, can we move on to our next topic?
Sorry, doctor. I think I have a question. Do we need to know? Do we need to like send for LDH for peritoneal?
LDH, if we highly suspecting of malignancy, we can send, but usually LDH more on likes criteria. Just like our pleural effusion, likes criteria, the ratio if the pleural LDH over serum LDH more than 0.6, it goes to exudative.
All right. So we don't really use for this one.
Yeah.
Okay. Thank you, doctor.
Assalamualaikum. Good morning, everyone. My name is Kameelia, and I will be the last presenter for today. So, the last topic is oxygen delivery. So, sorry. Nampak ke?
Nampak.
Nampak?
Okay.
Ah.
Okay, so as we all know, oxygen, we need oxygen for cellular respiration in our bodies, and thus it is essential for cellular function and life itself. Thus, for various different reasons, the amount of oxygen our patient is receiving isn't enough. Then we need to increase the level that is being delivered to them, and we have many different ways of doing so. We have the first kind of category, which are going to be non-invasive devices. So, in order for a patient to be able to utilize a non-invasive device, they need to be spontaneously breathing. So for non-invasive device, we have low flow and also high flow devices. So the difference between low flow and high flow is that the low flow device cannot deliver constant FiO2, and it does not meet all inspiratory demands. And the oxygen concentration will vary, and it is used in mild hypoxia and contraindicated for patients with abnormal breathing. As for the high flow devices, it delivers constant FiO2. It meets all inspiratory flow demands. It is designed to deliver a specific oxygen concentration to patient, and it is indicated for patient with abnormal breathing. So our first group of low flow device is nasal cannula, or also known as the nasal prong. So this is the most common one. It is often used when their needs are low. Nasal cannula has two prongs that go into the nostrils, and then the tubing wraps around their ears, kind of comes back underneath their chin and rests on their neck. And we do want to make sure that it is not too tight and potentially cushions to prevent pressure injuries, especially around behind the ears. So the nasal cannula is capable of delivering anywhere from 1 to 6 liter per minute of oxygen flow through it, and this comes out about to 24 to 44 FiO2. The flow is actually limited, so turning the regulator above 6 liter per minute isn't really going to increase the flow through this device. So the nasal cannula can be combined with humidification for patient comfort and to prevent drying out the nasal cannula. So the humidification should be used anytime above 4 liter per minute of flow. And this nasal cannula, it can still help deliver oxygen to mouth breathers, but especially heavy mouth breathers and those who have blocked nasal passages, that the nasal cannula really might not be a good choice. The next non-invasive low-flow device is simple mask. This mask has a plastic mask that's going to cover the patient's nose and without a reservoir bag. And basically, it's just simple tubing. There is an elastic strap that goes around the patient's head, as well as a flexible metal piece on the nose that ensures proper fitting. This device is capable of delivering 6 to 12 liters per minute of flow, and it equates to 35 to 50% of FiO2. Although, if the mask is not fit properly, then we are going to have more room air mixing in and diluting the oxygen that's currently being delivered. So a simple mask often has an attachment for nebulizers, and this is going to be for medication delivery. There are small openings on the sides of the mask that allow for proper mixing of the delivered oxygen with room air to get that proper FiO2 concentrations. And these holes allow for CO2 to escape. So that being said, it is important when we have a minimum of 6 liter per minute of flow that's being delivered through there, and this is going to ensure that the CO2 is flushed out of the mask and is not rebreathed back by the patient. So if we were to run this at less than 6 liter per minute, that CO2 is going to get trapped in there, and that patient is going to be rebreathing that back in, which is obviously not good for them. So a simple mask can deliver slightly more oxygen than a nasal cannula, but it is more preferred for heavy mouth breathers. Next is Venturi mask. This is like simple mask, but it is capable of delivering precise oxygen concentration. So here we have 5 colors: blue, white, yellow, red, and green. So blue, it can deliver oxygen 2 to 4 liters per minute. White, 4 to 6 liters per minute. Yellow, 8 to 10. Red, 10 to 12 liters per minute. And green, 12 to 15 liters per minute. Next is face tent. So this one is sort of like where you have this shield or tent around the patient's face that the oxygen is going to come into and fill the area around the patient's face, providing the concentrations that we want to deliver. This face tent can be a good choice for patients who do not tolerate wearing that simple mask or the venturi mask. And a face tent are capable of delivering 4 to 12 liters per minute, which equates to 24 to 60% FiO2. And then the last low flow non-invasive oxygen delivery is rebreather mask. There are 2 different kinds. First is partial rebreather. This is like a simple mask, but it has a reservoir bag of 100% oxygen that is attached to it. But we need to ensure that the reservoir bag it inflates and that it's not obstructed or anything. And then it has holes on the side of the mask that still allow for air movement in and out to dilute the oxygen delivered, as well as allowing CO2 to escape. And so we do still have that same minimum 6 liter per minute in order to prevent that CO2 rebreathing. Partial rebreathers are capable of flows anywhere from 6 to 10 liters per minute, which gives us 35 to 60% FiO2. And then we have non-rebreather mask, and this is actually a non-invasive device that is capable of delivering the highest concentrations of oxygen with low amounts of flow. So this is just like the partial rebreather. There is a reservoir bag, except for the holes on the sides are actually replaced with one-way valves. So this allows the expired CO2 to escape out there while closing back off, ensuring that the oxygen that's being delivered is exactly what we want. So in other words, when we use non-rebreather mask, we are unable to inhale anything that we exhale. And this mask is capable of flows from 6 to 15 liters per minute, and this equates anywhere from 60 to 95% FiO2. Next group is high flow device. First is the high flow nasal cannula. This is a special type of nasal cannula that allows for a very high flow of oxygen delivery. They can deliver up to 40 to 60 liters per minute of flow and up to 100% FiO2. There are adjustments for both the FiO2 being delivered via an oxygen blender, as well as adjustments for the flow rates that are being delivered. Because of this high rate of flow, even if someone is a mouth breather, this device is going to work just fine. And a high flow nasal cannula, it must be humidified and also have controls to adjust the temperature of the air being delivered, which typically we're gonna have warm humidified air being delivered to the patient. So this is a very high level support device and it can really deliver very high levels of oxygen at very high flows. Next is CPAP.
Sorry, your picture just now, that one is, this one is usually, this one is there's a prong. For
Nasoprom,
high
yeah.
flow, yeah. But high
Yeah.
flow cannula, we use other tube, not like this one lah. It's
Yes.
more, yeah. It's more
I just
bigger.
I just
Yeah, because
noticed
this,
the wrong picture. Sorry, doctor.
uh,
For your information, this is actually the nasal prong for the high flow nasal cannula. It's a different picture. You can Google it. I'm so sorry. Okay, so next we have CPAP and BiPAP. Basically, this device it delivers positive pressure to our patients via a mask that will cover their nose and mouth and then is secured tightly around their head to ensure that we have a good seal. And this can often used to prevent intubation in some patients, but we do need to be it do need to be utilized on conscious patients. So, the difference between CPAP and BiPAP, as you can all recall, Daniel has actually delivered an OSCE tutorial about the oxygen, right? There's a type 1 and type 2 respiratory failure. So, basically, type 1 respiratory failure is the patient is hypoxemic and there is a failure to oxygenate. Whereas in type 2 respiratory failure, the patient is hypercapnic and there is a failure to ventilate. So for CPAP, continuous positive airway pressure, CPAP is beneficial for patients with hypoxemia respiratory failure. So CPAP is a good option in helping patients who have congestive heart failure. And the reason for this is because CPAP usually increases our patients' intrathoracic pressure, and this can ultimately reduce their preload and improve their cardiac output. And CPAP is also beneficial in patients with obstructive sleep apnea to really help keep open their airways. And then for bilevel positive airway pressure, it is useful for patients that have hypercapnic respiratory failure or combination of hypoxemic and hypercapnic respiratory failure. So this is a good option for patients with COPD as well as patients with heart failure. Like that, it is a really good option to help and prevent intubation or if we need to wean really difficult patients from the invasive ventilation. So moving on to our last piece of device, which is the invasive device. Here are the common indications as to why we need to use invasive devices. First is unconscious patients, hypoxemia, refractory to non-invasive oxygenation, hypercapnia with altered mental status, inability to protect the airway, and in surgical procedures. So for our invasive device, we have a ventilator. So this requires intubation with an endotracheal tube in order to have full control of the airway, as well as full control over the breath that we are going to be delivering to them. So this ventilator, it delivers positive pressure breath and it allows for more control over many things, including the rate and the size of this breath, as well as the percentage of oxygen that's being delivered, which of course can go all the way up to 100% FiO2. So that is all from me regarding oxygen delivery. Thank you.
okay, thank you. This is the last presentation, right?
Yes.
Ah, okay. For the official delivery, I think the most important thing you have to know which type of oxygen delivery. Either it is nasal prong, venti mask, high flow mask, NIV, non-invasive ventilator, and then for special intubation, we have to go to ventilator lah. And then you have to know when to adjust the oxygen. As obviously, you have to know your ABG, type 1 and type 2 respiratory failure. Um, because you are entering the medical ward, right? So in what you may see various type of oxygen delivery. Most of them, in general ward, you can see nasal prong, ventimask, high flow mask, and then high flow is second order for ventilated patient will be in ICU or high dependency unit, medical high dependency unit. Any questions pertaining to all? Okay.
Doctor, on the previous one about the SAAG,
Yeah.
doctor mentioned about the portal hypertension. So,
Mm.
when I searched it up, it was written that portal hypertension is considered when the SAAG level is more than or equals to 1.1.
Yes, sir.
So, when she explained, she said that it's considered transudate when SAAG is more than 1.1. So, when it is transudate, it is considered as the patient is also having portal hypertension, is it, doctor?
No, for only SAAG. We use SAAG to differentiate to determine for hypertension. Usually more than 1.1 is goes to involve the portal hypertension.
Oh, so we don't use that for to differentiate between transudate and exudate, is it, doctor? Because just now she said if the SAAG is more than or equals to 1.1, it is considered as transudative uh, ascites.
Oh,
Can
usually I use SAAG. I think the obvious one usually we use SAAG. But I have to check back. Either we can use for SAG for transudative, but usually we use SAG for hypertension.
also we only mostly use that for portal hypertension, but we don't use the value to differentiate between transudate and exudate, is it, doctor?
Usually, exudative and transudative we use for pleural effusion. We also can differentiate for ascites. Let's say patient presented with ascites, we can use SAAG, and also we can use to differentiate between exudative and transudative. But I'm not sure we can use SAAG for transudative, but SAAG for portal hypertension is yes.
Okay, doctor.
Later,
Thank you,
I'll
doctor.
check back. Okay.
Thank you, doctor.
If no questions, I think we can end our session today. So for subsequent week, OSCE will be with different lecturers, right?
Yes, doctor.
Yes, doctor.
Okay. All of you, most of you have a good, a nice presentation outlines and background. Are you using only PowerPoint or Canva?
PowerPoint, but we take the template from Slides.go.
Slides, cool. Okay. I learned it. Usually, I just use a simple PowerPoint and Canva lah. Okay. I think
Dia orang
that's
guna
all.
Canva juga.
I can watch that. Okay. Can I think our OSCE this for today involve all of you, right? 42, right? This group.
I think some people they don't present on OSCE as well. Like some people present.
Oh, but this group is mean for all right for what for the whole batch, right?
Yes, doctor.
One group.
Huh?
One group
One group
of hosting.
How many of you?
43.
43.
Yeah.
Because I think the participant only 30 plus.
Actually, doctor, there's some students actually share the device as well, doctor.
Okay. Sorry. That's why because we do online, I cannot see all of you lah. Okay, as long as you learn something, anything you can ask me lah. Okay. Okay, thank you everyone. Assalamualaikum.